So continuation of shoulder examinations, and then what are the factors that reproduce the symptoms that you have to look for, and what is the chief compliance, and then is there any limitation in functional activities or limitations in work related activities or limitation in recreational or athletic activities. So as I said, like the observations plays a vital role. Like we have to look for the symmetry of shoulder or hip, and when you look at the patient's posture, so we need to have the patient should have a good head position, shoulder position, pectoralis, scapular position, and spine position. And also we have to look for the atrophy of muscle tissue. And what are the visible defects that we possibly seen during observations, like ecchymosis, edema, inflammation, and deformities. As I said, like we have to clear the cervical spine. So we should have a thorough knowledge about dermatome, myotome, and reflexes, whether the reflexes is exaggerated or diminished, hypo or hyperreflexia. And the shoulder range, yes, we have both active and passive, active range of movement and passive range of movement, and then the ability to raise. If you ask the patient to do overhead squat or overhead movement, you should check the ability to raise from the neutral positions, and then functional external and internal rotation has to be assessed. And then also we have to assess these several factors like the painful ox syndrome, quality of the movement, whether they have a good range of movement or controlled movement. If they do not have uncontrolled movement, it's otherwise known as accessory movement. So we have to look into all the parameters and scapulohumeral rhythm and scapular movement and dyskinesis. So the passive range of movement is first the patient should do the passive range of movement with the patients, then normal side of a patient, and then abnormal side. And to rule out the neuromuscular system is already we did a manual muscle testing, and then resisted isometrics and the reflexes, and then gait disability or now so we won't be able to experiment all the physical tests with the patients who walks into a clinic with shoulder pain. So as we discussed, like by scrutinizing the patient's symptoms, we need to check whether is there any rotator cuff pathology or impingement sign. So to check the rotator cuff integrity, then we possibly we do a MT can, drop on and lax sign, lift off and belly press. So if it is an impingement, if you suspect that there is an impingement, to confirm. So what are the tests that you do for the impingement test is near Hawkins and internal impingements. And then if it is a biceps, do you think is like as you said there is involvement of biceps head between the greater and less tubercle. So what the possible tests that you can do for biceps tendon, such as speed, static and dynamic, and Eggerson's test. And the slap, if you talk about slap, a special test called speed test, grind test, clank and crank, anterior slide, active compressions, and biceps load test. If it is AC joint pathology, then spring shear, horizontal abductions, and then O'Brien. So basically, what is laxity assessment? So the grading of humeral head translations, is it moving anteriorly, inferiorly, or the posteriorly? So what is normal? That we need to figure out which one is normal, and then the other test called load and shift. Yes, the cross instability, and if it is anterior instability, you have to recheck at 45 and 90-degree retraction and apprehensions. And posterior instability, posterior dry test at 45-degree and 90-degree. Then posterior fulcrum push and pull. As I said, accessory movement assessment, it's been done. So one is inferior glide, posterior, anterior, and lateral glide. And yes, of course, the neurodynamic test also has been included in the shoulder examinations. Upper limb tension test 1, 2, and 3, and Demetum as well as reflexes. So palpation is much more important. Like if you look out for the specific structures, so like greater tuberosity where the rotator cuff is inserted, and biceps brachii, the proximal, and then the coracoid process, subacromial bursa, and then anterior deltoid, and infraspinatus for internal impingement locations, and then quadrilateral space, and fast rib, and then acromioclavicular joint. Then scapular mobility, during the scapular mobility, the patient tend to hear crepitations, yes and no. And then functional assessment, as I said, like we use PADI, DASH, and then American shoulder elbow surgeons form. Also, we use a UCLA shoulder form. So, to functional assessment to assess periodically. That's my simple clinical examination of a shoulder, but we also should know about so what is the impairments control, movement impairments in movement control in shoulder girdle. So like when you talk about the scapula and the glenohumeral joint respectively, the scapula has a tendency to move upward, downward, it elevate, retract, so wing and forward tilt. But when you talk about glenohumeral joint, so the head of the humerus has anterior translations, inferior as well as the posterior translations. So, so when you talk about scapula and which direction in which the scapula is moving more, which is excessive. So possibly the site and direction of uncontrolled movement in the scapular level happens in downward rotations, forward tilt, winging, elevation, retraction, and protections. So what happens, the site and direction of uncontrolled movement, that's the scapula is moving during the direction of uncontrolled movement. So what are the clinical examples of symptoms or presentation represent? So symptoms of subacromial, if patient's scapula are downwardly rotated or forwardly tilted or winging, elevations, retraction, protractions. If there is an uncontrolled movement which is listed on my left hand side, so possibly the clinical examples of symptoms or presentations, possibly impingements at the level of subacromial or coracoacromial, at the point of the shoulder in the region of the coracoid and anterior and lateral deltoid region, and could be from myofascial, articular, and neural structures. So what are the provocative movements, posture, and activities? Symptoms provoked by all movements is if patient presents to the anterior shoulder pain, if you ask the patient to lift, could be a provocative by provocating factor by arm movements and postures into elevations above 60 degree. So example, lifting, reaching, forward reaching, etc., etc. And then the last slides we have seen about scapular control. Now we are going to talk about glenohumeral joint. Is on my left hand side, if you look at the site and direction of uncontrolled movement, possibly at the glenohumeral joint, the head of the humerus has a tendency to move anteriorly, inferiorly, and posteriorly. So the same clinical exams of symptoms and presentations. Yes, the symptoms of subacromial, coracoacromial impingements, which means the point of the shoulder in the region of the coracoid and anterolateral deltoid region. And as we see in the previous slides, the source of pain may be myofascial, articular, or neural structures that has to be eliminated at the first at the topmost priority. So like when you talk about shoulder stability, yes, the articulating surfaces provide a good stability. Though it is not like a hip joint, but the glenoid cavity and head of the humerus providing articular by providing a good articulating surfaces. It will provide a lot of stability to shoulder, and then the stability also can be supported by a capsular and ligamentous, and also the synchronized activity of rotator cuff, biceps, deltoid, and the scapular muscles. And then, like, if you talk about dynamic stability, yes, what do you mean by dynamic stability? So the dynamic stabilizers are crucial for a strong sense of neuromuscular control throughout all movements and activities involving the upper extremity. For example, throughout the all movement, when you're performing shoulder movement, we should have the mobility, flexibility, stability, strength, endurance. So what the new technique is called neuromuscular control. So if you should have a good neuromuscular control throughout the all movements and then activities involving upper extremities, we should have a good neuromuscular control, sensory motor system, and then proprioception has to be functioned carefully. Now, so when you talk about muscle activities, I have divided into axioscapular and clavicular. So I hope you are all aware about the muscles: the trapezius, serratus anterior, levator scapulae, rhomboids, major and minor, pectoralis major, subclavius, and then SC, sternocleidomastoid. So furtherly I've divided what are the muscle activity at the scapulohumeral level and then axiohumeral level. And then yes, we already study about the force coupled relationship. So what do you mean by the force coupled relationship? So when you talk about force coupled relationship, the equal forces produce a rotation by pulling in opposite directions. Like when you consider the serratus anterior and the trapezius, force couple is the key component for normal function of the shoulder. So what are the functions of force couple? Yes, it rotates the scapula, maintain the glenoid surface in an appropriate position. Through the scapular rotations, positions the deltoid to maintain efficient in length of a muscle. Thereby, if you have a sufficient length of a muscle, you will be able to enhancing power and stability more on the shoulder joint. Also, the force couple prevents impingement of subacromial structures on the acromial arch. Also, they provide stable base, enabling the axiohumeral as well as scapulohumeral muscles to move the arm against the resistance. So these are the functions of force couple. And then when you talk about components, the components can be divided into upper and lower. The upper component include upper trapezius, levator scapulae, upper portion of the serratus anterior. When you talk about lower components, so yes, we have a lower trapezius and lower portion of the serratus anterior. So I've just illustrated a diagram saying that what are the components of force couple, which is already been described in the previous slides. But by seeing a picture, you'll be able to understand it more than what we discussed before. Then when you talk about scapulohumeral muscles, yes, the scapulohumeral muscle, it provides movement as well as dynamic stabilizations to the glenohumeral joint. So as we are all aware, the deltoid has got three fibers: anterior, middle, and posterior. So what is the function of anterior middle deltoid? It active. The middle deltoid remains active in all planes of elevations and become more involved at 60 degree. That's what we have been discussing with the scapulohumeral rhythm. And and anterior and posteriorly command in flexion and extension respectively. So when you talk about deltoid and rotator cuff force couple, yes, the line of pull to the glenoid face of the infraspinatus and subscapularis has to be estimated at 45 degree. And then when you talk about teres minor, it is still up to 55 degree to exert a predominantly downward shear, which peaks at 60 degree of elevations as well as compressive load. And moreover, the important point to be noted is supraspinatus remain active in all planes of elevations. That's one of the most significant fact to be considered, fact to be remembered forever. So what is what is the take home message today? The supraspinatus remains active in all planes of elevation.